So good morning once again. We're going to discuss epistaxis today. It's really one of those things that is very common when it comes to emergencies in ENT. And definitely as a medical doctor, everyone, I think, will have a chance of seeing this. And at least you should have the basics on how to manage it and know when it requires maybe more specialized treatment so that you can be able to refer these patients to get the best care that they should get. So epistaxis, the brief outline, you just have an introduction about epistaxis, then we'll go through the relevant anatomy, and then the causes of epistaxis, and then how you can be able to manage and which patients would definitely need extra care or additional treatment or surgery so that you can be able to recognize these. So putting it simply is epistaxis is basically bleeding from the nasal cavity. It could be either from the nasal cavity or the nasopharynx. It has a bimodal distribution where we have a first peak, which is a peak among children below 10 years, and then the second peak among adults who are between 35 to 50 years of age. And usually the first peak, which is below 10 years, it's the highest, whereby you find that 90% of people have had at least one episode before the age of 10 years old. So you find that the commonest causes are most likely things like when children put their fingers in the nose. So you have nose peeking or infections, for example, upper respiratory tract infections with dryness of the nasal mucosa. So we'll look through the relevant anatomy, and what we are basically interested in is the blood supply to the nasal cavity. We know that the nasal cavity has a rich blood supply. You have arterial supply from both internal and external carotid arteries. So they have branches, and you find that epistaxis itself, it can be divided into two. We have what we call anterior epistaxis and posterior epistaxis. The anterior epistaxis is more than 70% of the cases where what we call Little's area on the anterior septum. And it has all these artery, the greater palatine artery, the sphenopalatine artery. These are coming from the external carotid. And then you have the anterior and posterior ethmoid arteries, which are branches of the ophthalmic artery, which is a branch of the internal carotid artery. So the anastomos in the nasal cavity and in the septum, in this area, they form a plexus, which is called Kieselbach plexus, from the German otolaryngologist who described it. So you find that this area has two names. One is from the American scientist, or ENT surgeon, there are two people who described it initially, Dr. Little and then Kieselbach. So Kieselbach describes the plexus, well, Little describes the area. So you have bleeding commonly from this area, and it goes to the opening of the nasal cavity, or even adults who have a tendency of picking area, and when someone picks their nose, it is easy to break down the mucosa and you end up with bleeding. For the posterior epistaxis, it's usually on the lateral nasal wall, and it's more common in adults. It's more common in adults, although it's also more, it's not as common. The cases are a lot fewer compared to the anterior one. So what we need to understand is the anterior epistaxis versus the posterior epistaxis. We've looked at the blood supply, and then we know that they're coming from both the external and internal carotid arteries, and then the thin overlying mucosa that could be over the Kisselbach plexus, which is to break down and hence have the bleed axis, as I had described earlier here, Kisselbach plexus, and it will come anteriorly through the nares, through the nose. And is very visible. Usually it's moderate to severe depending on what the cause is. For the posterior epistaxis, because it comes from posterior aspect, you find that more bleeding is I think my network has some issues. As I was saying, we could also characterize or classify the causes of epistaxis into localized or
Doctor,
systemic
maybe you would
causes.
please go back to the last slide.
The localized, the previous slide, sorry. So for the previous slide, I beg your pardon? So for the previous slide, I was talking about anterior versus posterior. Posterior. Could you give me a second?
Yes, doctor, we stopped hearing you from the previous slide. It's okay, doctor.
Okay. Just give me a minute.
Okay, doctor.
Sorry about that. I'm having some network issues, but I was talking about anterior and posterior epistaxis, where you have the anterior nose bleeding coming from Little's area, while the posterior one, there's an area we call the Woodruff plexus, and it's usually arterial coming from the sphenopalatine. It's more posterior to the middle turbinate. So for anterior, you have blood coming through the nasal cavity, while the posterior, you have someone having the bleeding going into the nasopharynx, and they will end up either swallowing the blood or spitting it from the mouth. less of it really comes out from the nasal cavity compared to what the amount of bleeding they are having. So you have to really look out for this. So when we look at the causes, we classified them as localized or systemic, where you have the localized case causes mostly in the nasal cavity, while systemic causes, like the word says, systemic. So for the localized, you have patients that have, it can be due to digital trauma or dryness over the mucosa that overlies the little area, so it's prone to break down and then you have bleeding. The cases of inflammation, for example, upper respiratory tract infections, allergic rhinitis, and still this will lead to breakdown of the overlying mucosa. You could have anatomical defects, for example, if someone has a septal deviation due to high pressures on one side in the nasal cavity, they are prone to getting bleeding. It could be neoplastic changes where you have tumors in the nasal cavity. Some tumors really bleed, so you have bleeding from one side. It could be because of intranasal drugs. This includes steroids, decongestants, or if someone keeps sniffing cocaine. These ones still, at the end of the day, break down the mucosa and predispose someone to bleeding. For the systemic causes, you have individuals that could be having bleeding disorders, for example, coagulopathies. If you're having platelet disorders, then they're prone to bleeding, but not only in the nasal cavity, but also elsewhere. Individuals that could have vascular abnormalities are also prone to bleeding, and this I think should be more vascular abnormalities in the nasal cavity. So it should be more of a localized cause. Also, because of liver disease, where you having inability for the body to make clotting factors, these individuals could also end up with bleeding from the nose, just as it could have bleeding from elsewhere. Drugs, there are different classes of drugs that can cause someone to bleed, and the drugs may be affecting their clotting. So you have anticoagulants. You could have antiplatelet drugs, for example. NSAIDs could affect the platelet activity of an individual, so you may end up with bleeding. Then you could also have some parasitic infection that affect the clotting capabilities of an individual. A good example of this is if someone has dengue fever or dengue hemorrhagic fever, you may end up with bleeding, but not only in the nasal cavity, also elsewhere in the body. So how would you approach a person who comes in with bleeding from the nose? What are you interested in their history? What will give you ideas as concerned to the cause leading to the bleeding or how bad their bleeding is? One, you'd be interested in the frequency. How many times does this person bleed in a day? How many times in a week, in a month, in a year? So the frequency of bleeding. Then the duration. How long does the bleeding take? Is it a short period of time? For example, let's say 10 to 15 minutes and the bleeding stops, or is it an elongated more than 30 minutes, more than an hour? So this sort of gives you the severity of the bleeding and what you really anticipate to find when you examine. Then you also need to find out the severity of the bleeding. Is it a few drops? Do they need to put something in the nose? If it is a hanky, how many hankies do they use? Really, you're interested in finding out the blood loss of this person. So remember, we talked about two things, anterior and posterior, whereby posterior, what you see anteriorly may be very little compared to what the patient has swallowed. So in this case, you're also interested in knowing Are they vomiting blood? Did they feel like they are swallowing blood? Because for someone to be able to vomit blood, that means they've actually ingested more than 500 mils of blood. So by the time they tell you that they are vomiting, then you know it has been really severe bleeding. Then you're also interested in knowing, is it from one side of the nasal cavity or is it both nasal cavities? Because if it's unilateral and it keeps happening, you have to rule out any tumors in the nasal cavity that could be causing the bleeding. Because if it was just, let's say, nose picking, uh, you don't expect the child to keep picking one nose. No, they usually change sides. But if it is clearly on the one side, then you have to investigate more and make sure you don't miss a tumor that may be in the nasal cavity that is causing bleeding. And then you're also interested in the general outlook of the patient. Um, do they have history of collapsing after bleeding? Basically, it's telling you how severe the bleeding is. Because if it's minor episodes, you are also interested in knowing the what happened before the bleeding started. Were they picking their nose? Did they have a flu? Were they sneezing? So it sort of tries to bring to you what could be causing the bleeding in this case. Did it start on its own? Were there any preceding events that occurred? So all these would be informative on what to expect and what you will find when you examine the patient. So for your clinical examination, first and foremost, you're interested in the general exam. How is this patient presenting? Are they weak? Um, are they, do they look normal and strong even before you touch them? Is the bleeding, what does it look like? What do they have? They could be carrying along the things that they've been bleeding into, for example, hankies or clots or all sorts of things. So you're interested in looking at them. Or even at that point, they may come to you when they're actively bleeding. So you need to see how much of the blood is coming out. So in the general exam, you're interested in how the patient presents. Generally, when you look at them, then things like jaundice, pallor, bruising, because this can point you to a more systemic cause of the bleeding. For example, what we talked about, liver disease, bleeding, coagulopathies, platelet disorders. Yes, those that could point you to that direction. So when you come to examining the nasal cavity, what you're interested in is crusting, and crusting is basically around the littles area. This may be in a patient who's not actively bleeding. So if you have crusting, you know that yes, that is where the origin of the bleeding is. For some people, you can be able to actually see the vessels that are bleeding. Um, you may be able to see intranasal masses. For example, if someone has a tumor in the nasal cavity. So this is to inform you what the meant will be. Investigations that you can do, these are really dependent on what you have got from history and examination. They will inform you. Because for minor bleeding, a child was picking the nose, you may not need to do any investigation. You may just need to, talk to the child, talk to the patient, teach them how to do first aid, and then maybe depending if they have allergies, treat them, whatever is causing them to pick their nose. But as far as investigations are concerned, they may not really need them. You're more in the cases where you're having moderate to severe bleeding, that is where you may need to do investigations. And these will be directed by your history. They'll be directed by your examination findings. So you also, in the cases where you're having prolonged bleeding, which is happening for longer than 30 minutes, or for cases where you're having someone bleeding from one side all the time, then you're more concerned. It could be a tumor coming in the nasal cavity that is causing them to bleed. So you basically need to investigate these to rule out that. And also children under 2 years. When a child under 2 years comes with bleeding from the nose, because we know below 2 years, they can't really pick their nose. So you're more concerned. Why is this happening? So you also have to investigate this, not to just let it go because it's suspicious. So the you can do. You have the hematological. You do not have to do this test for everyone. Like I have said, these tests really depend on how the patient has presented and how severe the bleeding is, what you have found in examination. So for someone who comes in with pallor, you'll be interested in doing the CBC. Basically, you're looking at their HB and then also all the others, the differential cell count. So in this case, you're interested in knowing, are they anemic? Is the bleeding that bad that they're having anemia that you need to correct? So that's why you need to do a CBC. Where you're suspecting maybe coagulopathies, you may need to do a coagulation screen. And in this case, you may have to do tests like prothrombin time, the activated partial thromboplastin time, the INR. So basically for these ones where you're suspecting the coagulopathies, that's where you do that. You may need to do platelet function assays. And in the case where you're suspecting tumor in the nasal cavity, that's where you have to do a CT scan. In case, and the CT scan will have to be contrasted so that you can be able to see the tumor extension, whether it's eroding bone or not. Really, the MRI is more to, if you have brain involvement, you'd want to know how bad it is. So these, at the end of the day, they would help someone who, they would help in staging for the case of tumors. But if you're not suspecting a tumor, and even in your examination, there's nothing that is suggestive of a tumor, there's no need for a CT scan or an MRI. So you could as well just manage the patient. So when someone comes in with a bleeding, how do you manage? You realize that actually for most of the cases of bleeding from the nose, they actually do not come to hospital. Over 60% of the cases are managed from home or from the community. So for someone who should be able to teach them the bare minimum, and this is how to be able to control the bleeding at home, at least to have the first aid. And this is basically for the patient to sit up, then they lean slightly forward, and then tilt the head forward and pinch the ala nazi. These are like basically the sides of the nose, so that they can be able to occlude the nasal cavity and compress the part of the septum that has the bleeding. Because we said is from the Little's area. So when you do that, at least you're putting pressure on Little's area, and this should happen at least for 15 to 20 minutes so that you're able to stop the bleeding. And I mean, if they come to hospital and you do this and bleeding is still continues, and then you have to do other things as well to try and stop the bleeding. You could have topical sprays where you can have vasoconstrictive sprays. For example, those that contain adrenaline. Although these ones really, there's very little effect. The best thing is to clean up the blood. If they can blow their nose to blow out the clots, well and good. If they can't, you have to clean up the nasal cavity, suck out the clots, and then look at where the bleeding is. If you can see the bleeding, then you would do the nasal packing. We shall be able to demonstrate when you actually come around to the clinic for the tutorials. So how you do the nasal packing, anterior nasal packing mostly, because this would be the next step. If the nose pinching is not working, then this would be the next step to actually try and apply pressure to the bleeding point so that you stop the bleeding. But for the case, if you've done all this and still the bleeding is continuing, then this patient may require more than this, may require more than packing. For some, you may need actually surgical to stop the bleeding surgically. For example, you may have to like get the sphenopalatine, which you may not be able to do. So for the cases that even with packing and the patient is not improving, um, you need to refer this to the nearest ENT so that they can find a way forward for the patient. And also depending on what you got from your examination findings, if you find that they have other bleeding disorders, I mean, these are patients that you may actually need to refer to the physician. If they have intranasal tumor, you may need to, not that you may need to, you have to refer this to an ENT so that they can fully work them up and sort of give the definitive management. But before you can do that, the basic is to first ensure that you stop the bleeding. So that is where the packing comes in before you refer the patient. Just a quick question. We always tell people, I mean, you have to for the nasal pinch, and there's what is done. People, there's patient A and B. We need to know which is the right one. Is it A or is it B when you're trying to stop the bleeding? Because it all depends. If you're giving the pressure to the right place, then that's when you expect results. Sometimes results, you don't get the results because someone is holding the wrong place. So which of the two is the correct one? I hope the picture is clear enough. Is it A? Is it B?
I think it's B, doctor.
Okay, so definitely it is B. So here you're pinching you're sort of holding the ala. Ala just means the wings of the nose. You're holding them together, and in the process, you're compressing the Little's area on the septum. So for anterior bleeding, this should be able to work for you. And it should be 15 to 20 minutes. So you give it time to work, just like if you're having bleeding from anywhere, you'd want to apply pressure to stop the bleeding. So that's it. Any questions?
Yes, thank you so much, Dr. Ruth. I've seen there's one question in the chat. Meanwhile, other members, if you have a question, please raise up your hand. He was asking, is hypertension part of the systemic causes of nosebleed?
When it comes to hypertension, it has been associated with severe bleeding, but then it doesn't mean that everyone who has hypertension will have a nosebleed. So yes, there are many individuals who have had high blood pressure or who come in with high blood pressure and nasal bleeding, but then we don't conclude that it's because of the hypertension. I don't know if I'm being got right.
Yes,
sometimes people may come in with high blood pressure because it's more of anxiety when you start bleeding from the nose and the bleeding is not stopping. So you start getting anxious, and then the blood pressures may go up when they're not necessarily hypertensive. So it's one of those things. Yes, it's been found that people with high blood pressures can have bleeding from the nose, but then you have to rule out any other causes of the bleeding.
Okay, thank you, doctor. Maraka has put down her hand. Maybe the question has been answered. So, Mujuni, please unmute and ask your question.
Good morning, doctor. So
Morning.
my question is, how would you manage a patient with posterior nasal epistaxis?
So for the posterior epistaxis, you'd have to do a posterior nasal pack, and basically these ones you really need to refer them. You really need to refer them because usually the bleeding is nasty. So you'd have to put an anterior pack and refer these ones as urgently as possible. But
Okay, thank you.
for posterior nasal, bleeding, it's posterior nasal packing.
We have another question from Bire. Bire, please unmute and ask your question.
Thank you, Dr. Ruth. My question is, what's the role of vitamin K in the management of epistaxis? I've seen it routinely prescribed by ENT specialists. Thank you.
You've seen it routinely prescribed. Well, like I said, for the causes of epistaxis, there can be different causes. It could be a localized case or a systemic case. So for the case of a person who's having coagulopathies, maybe due to liver disease, that the vitamin K may be recommended there. If it is more of a local cause, then you do not need the vitamin K. So you treat the patient according to what you're suspecting the cause to be their bleeding. So not every patient would need vitamin K.
Okay, thank you, doctor. We have one last question from Kamal 17. I don't know who that is. Please unmute and ask your question.
Thank you so much, doctor. I wanted to inquire about the role of the local anesthetic in management of this patient. And also, is there a need to use tranexamic acid in managing this patient?
So for the local anesthetic, just like the name itself, local anesthetic, basically try and numb the nasal cavity. So you may do this you can do this when you're going to put the nasal pack to reduce pain and also reduce anxiety. You're already putting something in someone's nose. They are scared from the bleeding. You don't want to add pain to that. I mean, if there's no pain, the patient will be more cooperative, because putting the nasal pack, you're going to do it when the patient is awake. So the role of the local anesthetic is really pain management as you're trying to put the nasal pack, and this makes the patient more cooperative as you try to put the pack. The other question, I'm sorry, I've forgotten the other question you asked.
The other question is related to the use of tranexamic acid. Can it be used in managing these patients?
Tranexamic acid. So for tranexamic acid, if you suspect that this patient's blood is not clotting well, so then that's when you use tranexamic acid. Sometimes the bleeding is so severe that you're trying to give the patient all the care that you can get before you're able to investigate them. So at times we give is bleeding severely. So you're not yet sure what is causing their bleeding. So as you're trying to put the nasal pack to stop the bleeding, you may also give these other medications before you get the results. So tranexamic acid is one of those that you could actually give to help with the clotting. So it's not always recommended, but at times in the cases of severe bleeding, you will have to give it, because here you're working at basically trying to manage an emergency. You may not have had the results given to you yet. So you will not say, I'm waiting for the blood workup before I give the care this patient needs. So it's a yes and no for tranexamic acid.
Thank you, doctor. There are two more hands up. I don't know if you can accommodate. And there's
It's okay. It's all right.
okay. The question in the group is, how do you distinguish capillary and arterial nosebleeds on examination? That is from Chiinji Edison.
Okay.
in the chat.
So capillary and arterial. So for the arterial causes of nose bleeding, the bleeding is more severe. Just like you know the size of a capillary, and then you know the size of an artery, and how much blood you can get out of an artery. So you find that the capillary bleeding is less or very little volume of blood. When you compare it to the arterial, it's more of a pulsatile bleeding that is having a lot severe to moderate amounts of blood. So you can tell from the volume of the blood loss of the patient. And the other thing is that you could be able to see these vessels that are bleeding. So the differentiation can be from the volume or what you've seen on examination of the patient.
Okay, thank you, doctor. Then the last, Alex, please unmute and ask your question.
Okay, good morning, doctor. Good morning, doctor. Hello, good morning, doctor.
Good morning.
Okay, thank you for the lecture. My question is,
Please ask your question.
yes, there is a patient I usually see. She usually menstruates whenever she is menstruating, she gets nose bleeding, and I couldn't tell the relationship between menstruation and nose bleeding. That's my question.
Menstruation and nose bleeding. Okay, thank you for the question. Well, for many of these things, the research that has been done, there's really no association between the two. But you could find that because of the hormonal changes with the menstruation, because of the hormonal changes, you could have nasal mucosas that could be more prone to drying, let's say that. And really, basically, they may not be clearly related, that because of the menstruation, then you definitely have to have nose bleeding. Because, I mean, very many more individuals they menstruate, but they don't bleed from the nose. So I think for her, really, I think it's to do with drying of the nasal cavity, depending on how long someone menses may be, or how badly affected, do they have pain. You find that at times people are unable to sort of feed or take in fluid, and this will later have, they are dehydrated. Dehydrated means a dry mucosa. Dry mucosa is more prone to breaking down, and then you end up with bleeding. So it may just be something that is predisposing them, but not necessarily correlation between menstruation and bleeding from the nose. So this is the person you really need to, if they're having the nasal bleeding, you need to really examine the nasal cavity and ensure you try and find where they're bleeding from. So that if it's a dry mucosa, then it's something that they can anticipate and prepare for it. And then you can give them probably ointments that they can use in the nasal cavity. For example, sometimes we improvise with tetracycline ointment, or there are other sprays that have been made for that. For example, olefin spray. So basically to try and moisturize the mucosa and this in a way stop the bleeding from happening or prevent it from happening.
Please
I hope
unmute
I've
and ask
answered.
your question.
Okay. Yes, thank you, doctor. So my question is in relation to if someone has epistaxis and CBC is done, and the platelet count is probably around, let's say 90. Will it be prudent to give whole blood, or it would be much better to give fresh blood?
Well, so you've commented about the platelets. You've not commented about the HB of the patient. So
If the HB is around, let's say 4.
if the HB is 4,
Yes.
I mean, because if you're trying to help them, you definitely need whole blood, and not just any whole blood. You'd want blood that actually has clotting factors as well, and this is more fresh whole blood. So it wouldn't you would not be managing the patient if you're giving them only platelets, yet you've realized that even their HB is down. They would benefit from all the blood products because they've been losing all blood products. When you're bleeding, you're not only bleeding out the platelets, or you're not losing only the clotting factors. So for this patient, you'd have to give them whole blood, but then again, you'd have to investigate why are their platelets that low. So, like I said, for this particular patient, that's why you need to also determine the platelet function. So, doing the platelet function assays would also be key to helping them.
Yes. Okay, just one more question. I've seen some of the COVID patients, okay, for prophylactic prevention of DVT, who are elderly, they're being given Plexin and probably Plexin and warfarin. And sometimes patients come back with, okay, some patients have epistaxis. So will it be, does rivaroxaban also sometimes present with epistaxis? Does rivaroxaban also present with epistaxis?
I beg your pardon?
Rivaroxaban.
Does what?
Rivaroxaban, also an anticoagulant, can it also cause epistaxis? Rivaroxaban.
Okay, so at the end of the day, what can predispose someone to bleeding is any medication that is an anticoagulant.
Yeah.
Yeah. So if not given in the right doses, or it's more prolonged than usual, these are things that you can really look out for. And if you get a patient who's bleeding and they've also been on this medication, you sort of have an idea why they're bleeding. So you may actually have to stop these medications so that you deal with the bleeding. But of course, the emergency management is to stop immediate bleeding, and this you may have to do a nasal pack, or for vessels that you can actually see, you can be able to cauterize them. Yes.
Thank you so much.
Okay. Any more questions?
Doctor, what are the
Kobsinje, please ask your question.
notably commonest causes of posterior nosebleeds in our setting?
In our setting, posterior nosebleeds, like I said earlier, that they're more common in adults. They are really rare in children. And the commonest associations that we found are individuals with uncontrolled blood pressures, high blood pressure, or individuals with atherosclerosis. So you find that they are also having high blood pressure. Although what I wanted to emphasize that When you get a hypertensive patient who is also bleeding from the nose, you shouldn't always conclude that it's because of their high blood pressure, that's why they are bleeding. You need to sort of rule out any other causes. So it's more of a diagnosis of exclusion. So the people who commonly present with posterior bleeds are usually hypertensive, but you need to rule out any other cause of the bleeding to be able to conclude that it's because of their high blood pressures. Any more questions?
I think we have answered all the questions. Thank you so much.
Okay, all right. I think next week we will be having tracheostomy. If there are any changes, I'll be able to communicate, but I'll be giving the lecture. And I've already uploaded this to the LMS, whatever, so you can be able to access it.
Doctor,
Yes, please.
next week we shall be having exams. We are starting
You'll be
exams
having
for
exams.
end of semester.
Oh.
This
Okay. Okay, then we'll be able to reschedule then. I will get in touch with Dr. Jamila so that we let you know when next we can be having the lectures or what the program will be like after your exams.
Thank you.
Okay. Success in your exams and have a good day.
Thank you. Have a good day, doctor.